Welcome. Thank you for being here. My name's Jan Dick. I head up the education function for the Minneapolis Heart Institute Foundation and couldn't be more pleased to have you here. I think we picked the perfect day. Yesterday was really ugly, right? And then get ready for Monday. And we are just so pleased because last year we were virtual. And let's face it, that does not have the enjoyment of being here together with other folks that have this interest. Thank you for bringing friends and family. And if you came by yourself, you're not alone. And please build some new relationships while you're here, if possible, because we're all here to learn together, because this is an education event. So I wanted to first just say a thank you. Okay, I'm now clicking. Okay, there we go. It's got a little delay. First off, the lunch that you're enjoying, thank you, Edwards Life Sciences. Thank you, Abbott. For some of you, know some of the local names and so forth. It would have been AGA Medical and St. Jude Medical. And then our good friends at Medtronic. And I also want to thank Maya Hendel and John Rickert. They did all the work for this, so thanks, guys. Bang up job. Okay, our agenda is pretty straightforward. Soon after I give a little bit of an overview, I'll be joined by Dr. Paul Saraja, who will give an overview about valvular heart disease. So am I doing that?
No, it's going on its own.
Okay, that's fun. All right. So, and then Dr. Vinny Bapat will do a deeper dive around some of the therapies and approaches in this space. And then Dr. Bilal Murad will join with also our patient Chris, and we'll have a panel, which is really one of the fun parts of this whole event. And by the way, we've done this for about 5 or 6 years, so that's why I'm referring to the past. And then the very best part is the Q&A. So some of you have submitted questions, but in your packet, there's a card, so please drum up any other questions that you have throughout, and then we'll circulate and we'll pick those up. And then also at the very end, if you would be so kind to complete the evaluation so we can continuously improve this. Okay, so that's what we're going to do today. All right. Just a few words about the Minneapolis Heart Institute Foundation. How many people have not heard of the foundation before? Maybe you've heard of the Minneapolis Heart Institute. Anybody willing to admit? Okay, so yay, I get to tell you about it. All right, 40 years ago, cardiologists got together and said that they wanted to remain as active clinicians, but they wanted to do research. But they didn't want to wait forever to do it. They wanted to be agile, they wanted to innovate, they wanted to be speedy, so they set up their own nonprofit, the Minneapolis Heart Institute Foundation, and we're so proud of the progress that we've made over those 40 years. This cannot happen without our partners. So our partners are the Minneapolis Heart Institute, and that they are our clinicians, our principal investigators on the trials and so forth, and then, of course, Allina Health Systems, the patients from there. By the way, the Minneapolis Heart Institute is primarily operating out of Abbott Northwestern Hospital and United Hospital in St. Paul. So hopefully you may have patients here today that are from both cities. So basically the foundation, we are on this planet to do research and education. And I am again pushing the button. Okay, there we go. So great care and options for patients only come by doing research, right? And so we run clinical studies in 2 major ways. Number one is we work with industry, because industry is trying to look at new products and therapies, and patients are looking for better options rather than the traditional options, right? And then our physicians, in their spare time, I have no idea where they find it because they're active clinicians, but they want to study different things. They want to look at things that they're seeing with their patients right now, and that's called physician-initiated research. So we support both of those. But guess what? No research is any good unless it gets out into the public. So therefore, the foundation helps with manuscripts and abstracts, and supports the physicians as they present their findings worldwide. And so that is really exciting for us on that side as well. And then in the picture there, I just have one other fun pride point for us. We have a pre-med summer internship for young people who are aspiring to be physicians, and we've helped over 200 of them increase their candidacy for medical school. So really excited about that. I also want to just point out, and this is, I'm a layperson, I'm not a clinician, and one of the things I learned when I came to work here is, you know, the money to conduct research really doesn't, you know, just come from government or from other thin air. It comes, frankly, from grateful patients and other people in the community who believe in the future in options for patients. So we are forever grateful. Okay, now I'm going to just one slide, and then I'm going to turn it to Dr. Saraja. We are so proud of our Valve Science Center. This has been started in the last 10 years as a real area of focus to advance the science and advance the research in that area. And the group has done an incredible job. Led by Dr. Saraja, there's a team of multidisciplinary physicians who come together to find the best treatment options and the best options within research. And Dr. Saraja will tell us much more about that. Dr. Paul Saraja is the chair of the Roger and Lynn Hedrick Valve Science Center, and he also heads up the valve program at the Minneapolis Heart Institute. Again, he's tireless. If you haven't heard his name, be sure you know it. Look him up, and we're thankful that he's here today. Dr. Saraja.
Thank you, Jan. It's really a great pleasure to be back in person. As Jan mentioned, we've been doing this for about 5 or 6 years in honor of Valve Heart Disease Awareness Day. And this is a holiday that I wasn't quite aware of until a number of years ago, but it's every February 21st. And traditionally, we have held this in the evenings, but we thought we'd make it easier for you and do a lunch because sometimes the evenings get to be a little bit late. Sometimes we get blindsided by snowstorms, and it gets a little bit hard to get people here. So thank you all for being here and also coming in person to really make this happen. It's really just wonderful to see you all. So again, we're here for Valve Heart Disease Awareness Day, and I'm really, the mission of what we do at the Valve Science Center is to help address what we feel is this public health crisis. And I'm going to introduce this topic and then turn it over to my partner, Dr. Bapat, who's going to tell you about what we can do about this. But just to make sure that we're all kind of level set as to why we're here to talk about valves and heart valves and how they get diseased and how they can get treated. And for those of you who may not exactly know what a heart valve, they're kind of like these doors in the heart. And these doors, they're meant to be one-way doors that carry blood in one direction. And sometimes we're born with these valves as abnormal things, but a lot of times these valves can get more diseased as we get older. And so just to give you an example, so here on the left-hand side is what we think of as a normal valve. They tend to be these thin, movable leaflets that, again, are like doors, and they carry blood throughout the heart. But as one gets older, they can become diseased, and they can get these calcific nodules and have problems with opening or closing. And sometimes we refer to an inability to open as stenosis, or sometimes if they're leaking, we call that regurgitation or insufficiency. So you'll hear some of these terms thrown about for valves and how they get diseased. And we're here because we want to generate awareness of this problem. You know, when we have valves and valve heart disease, I think many of you may be familiar with these campaigns with breast cancer, prostate cancer, colon cancer. They're incredible campaigns, and not here to take away from that at all. But one fun fact that many people may or may not know is that when it comes to survival, one can actually live longer with breast cancer and prostate cancer than they can live with valve disease. Once somebody has valve disease, it's 1 to 2 years when they have symptoms. It's very, it's very hard to live longer than that. And right now in the United States, there are anywhere from 10 to 20 million people with valve disease, and unfortunately, a lot of them go untreated. And we have amazing treatments that are easier than chemotherapy, they're easier than radiation therapy, they're surgical, and they're getting more and more innovative all the time. And with that, I ask you to keep these thoughts in mind because we have something that's really malignant yet really treatable. And we're here to talk about that today. And I can't have a better person to talk to you about that than my partner, Dr. Bapat. Dr. Bapat is originally from Mumbai, India. He made his international reputation working in London and New York. And we were fortunate to have him join here a couple years ago to be our chair of cardiac surgery. And it's just been phenomenal. He has expertise in a whole range of surgeries, from the open to the minimally invasive or catheter-based approaches. And he is really just what we call a key opinion leader. He's published thousands of papers, given thousands of presentations, and it's just been exceptional. And most importantly, he's a nice guy. And so I want to welcome Dr. Bapat up here to give us an overview of valve surgery. Vinny?
First of all, thank you. Rarely cardiologist calls the surgeon a nice guy, so I think I should take that as a compliment. I have two passions, and it's amazing that one is heart surgery, of course, but second is golf, and it couldn't be a better venue, except it's not green. But thank you for that. These are my disclosures. I work with most of the valve companies for many reasons, but a lot has been with two educational ventures, understanding heart valve design, what we can do better. More importantly, I think, is to understand limitations of every technology. As Paul alluded, when I started my heart surgery very early, I thought, well, everything must be known by now. There are 4 chambers, 4 vessels, 4 valves, blood goes in one direction, and it's nearly 26 years later, we are still learning more and more about it. So if you look at these heart valves, essentially they have to maintain unidirectional blood flow. If it cannot maintain unidirectional blood flow, back pressure happens, and that's why most patients get symptoms and most patients get affected negatively. So there are a lot of common valve conditions, the commonest being aortic valve, and I think some of you here are very familiar with that with first-hand experience. This valve kind of sits in a house or a sinus, and then the main artery comes from it. And all these 3 things are related to each other in many ways. That's why many times when patients come to us and say, my neighbor had a heart valve disease and I have the same problem, but the operation is completely different, because we have to look at things in a totality rather than just isolation. As again, Dr. Saraja showed that beautiful slide, valve, generally aortic valve has 3 leaflets, but many of us are born with 2 leaflets. And when it is 2 leaflets, they work very beautifully for a time, but the blood flow is more turbulent, and that's why these patients tend to present in their 4th decade to 6th decade rather than 7th to 8th decade. And this is what happens to the valve. If there's more turbulent flow, there is wear and tear. Body always heals with calcification, and that's why this valve cannot open properly. It's like a hinge which is a bit stuck, or it sometimes cannot close properly, and that it leads to leakage as well. Many times, the treatment for stenosis or narrowing is different than that of a leakage. So again, when we look at patients differently, and we look at them that can we treat with one therapy or the other therapy, depending upon whether it's leaking or whether it's become narrow. Mitral valve actually is an extremely beautiful and a very complicated valve. Unlike the aortic valve, which is pretty simple, I would say, mitral valve is very complicated. And compliment to most of the women here in the audience, my boss always used to say aortic valve is like a man, very simple, while mitral valve is very sophisticated and very difficult to understand. So this valve has got 3 important parts, and the most beautiful thing about this valve is this valve closes under tremendous pressure. And just imagine 70 to 80 times a minute it has to beat throughout our lifetime, and still it works very, very well. And when we look at them as surgeons or cardiologists, it's actually a very thin and a very beautiful creation of the nature, I would say. This valve can also become narrow or can become leaking, which is what is more common nowadays. And then the treatment options are different. So when you come to us, patients always get, and it's hard to explain sometimes, but I always like to simplify them in boxes. There are 3 options for anything. There's medical option, catheter-based option, and surgical option. We have to understand what fits the patient best. And then most importantly, we look at what is the risk for each option. We have to look at age, we have to look at the heart function, because it can be different. I can give you an example of a young patient whose heart's not functioning very well, the risk is going to be higher. While it's an elderly patient whose heart is working very well, the risk is going to be lower. And the third thing is, how are your kidneys, how are your brain, how is the liver working, how is the lung? And this is very important. So we take all that into account and then decide what therapy is better for each patient. We also throw a lot of names at you. You know, we're going to get an echocardiogram. We're going to get a 3D echocardiogram. Then we tell you we're going to get an angiogram. And all these things are really the pieces of puzzle. We have to assess you in totality. We have to first look at the function of the heart with echo. We have to look at the blood supply of the heart, whether it's good or bad, with angiogram, for example. And now, of course, we have got beautiful imaging called CT scan. And it's not just like one panel after another, but we can create really nice 3D reconstructions. We can virtually implant a device and see whether it fits you or not. So this actually gives us we have become wiser. Without doing your procedure, we can actually look at what will work best for you. So once we do all that, then we start thinking of what treatment to do. And I think we all should be really proud that Minneapolis was in the forefront of this. And I must say that Dr. Walton Lillihei and the Visible Heart Lab is one of my favorite places to ever visit. And these are the 4 pillars of cardiac surgery who started it. But they also recognize that time is going to change. Patient demands are going to change. So surgery is always going to be, I would say, second option if we can do something better with a less invasive option. So these are really wise people, really, who knew long time ago, 70 years ago, how the wind is going to blow. So when we look at these things, we have to always align ourselves with changing paradigms. And changing paradigms is not just what I like to do. Changing paradigm is how the disease pattern is changing. What is the life expectancy? Life expectancy is getting longer in Western world. So we need to adjust our therapy areas around that. And lastly, but most importantly, patient expectations. And this is really important today. So just to give you an example, for aortic valves, when heart surgery started in 1950s and 40s, essentially they were looking at congenital anomalies with babies. And slowly then it became rheumatic heart disease, which a lot of you must have heard of. Slowly that's gone away, and now we look at degenerative heart disease in more grown-up people. So we really need to understand and make changes in our therapy area. Now, a lot of people are scared of this picture. It's like opening the chest and it's going to fall apart. But there are some of my patients here in the audience, and it actually doesn't. We have to do, I always say, length of the scar necessarily doesn't determine your outcome. What determines your outcome is how well we fix the problem. And that's really important. And why we say that is we take into consideration, if you remember, those 6 or 9 things in our armamentarium. This is essentially open heart surgery. What we are trying to do is a heart-lung machine, open the heart, fix the problem. And usually it is either repairing or replacing a heart valve. And when we say replace, we have these sutures. It's very, not very technical, I would say, very crude. You put sutures and you just tie with your hands. But this is how the heart valve journey started. This is many, many years ago, a collaboration between a surgeon and an engineer. And then they created this. Just keep this moving picture in your mind. There's a significance of this. This particular heart valve was implanted around 50 years ago in a patient. Mechanical valves came, again, we need to be proud, 1971, St. Jude bileaflet mechanical valve introduced in this very city. It's the commonest valve design now used all over the world for mechanical valves. And then, of course, the tissue valves or biological valves started in England by Dr. Ionescu Shiley. And then from then on, we have very good third generation and fourth generation devices. But for all these valves, we still need to access the heart. And then we have graduated from that big red line in many patients to the green line or the orange line or the blue line. And the whole emphasis is, faster recovery. But more important for me is psychological impact. I think telling a patient you're going to have a keyhole operation makes such a positive impact on people that they invest in their recovery much more than if we just say we're going to open your chest fully. However, in some patients, that's still required. And when you explain everybody properly, I think the investment returns. But this is what keyhole looks like. It's a relatively much smaller incision, and actually much smaller and smaller in appropriate patients. And the trick is to use them when it's appropriate and not just focus on the length of the scar, but how you fix the heart. And now all the CT scan analysis which I showed you really helps us with that. It helps us to understand if I do a very targeted exposure, am I going to fall in trouble? And if I know I'm not going to fall in trouble, I can do that safely. And this is very important. We can look into the body before we actually open it. We can plan everything before we do this procedure. This is one of the strongest men in universe. I think you have heard that terminology. They lift cars and tires and everything. This is a patient I operated in London many years ago. And funny enough, he came to see me 7 days later, and the hospital organized a photograph session and things. And he just picked me up. And I was like, whoa, And this is because his breastbone was not touched. If we had opened his breastbone, his career, his passion would have ended. And we could give him that option. His valve was leaking. He was functionally born with that bicuspid valve, which was leaking. There was no other option in this gentleman. So we have extrapolated this now. In some patients, as we pass age of 70, 75, if even there are two problems, like a valve and bypass operation, can we be creative about this? And this is where my colleagues like Dr. Saraja and Dr. Murad come into play, is we discuss these cases and we do different things now. So essentially, we can fix the heart valve with open surgery if needed, and then do PTCA or angioplasty so as to treat the patient properly. So a lot of these new algorithms have come now in our practice. The way I look at it, in 2000, when I started in London, we used to do everything through full sternotomy. And now suddenly, since 2013, we have got like 6, 7 options of treating each patient. So again, I think the modern science has really helped us a lot in getting the best benefit to the patients. TAVR has been the biggest revolution in my mind in last 20 years. 2002, we recently celebrated 20 years of it. Professor Alan Cribier, who is one of my mentors, did the first case in 2002. And since then, it has changed rapidly. And I'm showing you this picture for 2 reasons. One is Dr. Marty Leon with the beard. He's a very famous cardiologist. And Dr. Mike Reardon is actually the surgeon. And this is a very collaborative development which has happened. And this transcatheter technology really has benefited millions of patients now. And the reason I say millions is this is not just treating aortic valve today, but this is going to treat many things in next coming years. This is what TAVR looks like. Somebody in the audience asked me, what is TAVR? And this is essentially the balloon expandable device, which you put it under X-ray and echo guidance if needed. And then what you do is just inflate the balloon to fix this heart valve. And this heart valve stays there. Remember the picture I showed you? We suture it with our hand. But this stays there because there's calcification. If there's no calcification, this particular valve may come loose. So this is what we don't want. And this is how this valve works, while there's another valve which is self-expanding, as we call it. And what this does is slightly different. Now here you don't need a balloon. This is made of a metal called nitinol. And then this, when it's exposed to the body temperature, it just expands naturally. It's like a flower blooming. And you will see it here that as we unsheath this or uncover this, it comes in contact with body temperature, which is 37 degrees centigrade. This valve will slowly expand and be exactly fixed in the position you want. So each of these 2 technologies are the dominant technologies currently which we use here. There are a lot of ifs and buts of when we use which one, but both do the same job and both do a very good job at it. And the main difference between these two, surgical valve and TAVR valve, of course, is that in the surgical valve, we take out the calcified valve, while in TAVR, we just don't. We use it to fix it. And initially, we had a lot of hesitations about it, but now, science and a lot of investment from investigators, imaging, we know now that it works very well. I show this slide to everyone because 93 to 94% of patients can be treated by TAVR. But there are still some patients where TAVR may not be ideal for you. So this is, for example, the best TAVR patient. We can approach it through the leg, no problems at all. We know the calcification is uniform, etc. But then we can get different anatomy. Like you can see that the leg arteries are tortuous. There may be risk of injury when we do something. Or you can have other pathologies by which we can actually cause more damage while getting the valve to the heart. So these are the cases where we can approach it differently. Rather than going through the leg, we can make a small cut in the chest, or we can make a small cut just below the shoulder or just under the neck sometimes, and we can still get that TAVR device in the patient, I mean. So we have seen a reflection of this in the practice in United States now. TAVR is done more than open heart surgery, but it also shows that the open heart surgery numbers are still same. There are a lot of patients who still need that. If you remember that picture I showed you, this is the valve from 45 to 50 years ago. And this patient we treated with a TAVR device now. So you can see a really old valve and a really new valve functioning beautifully together and benefiting the patient as the patient has got older and the risk has got higher. So this is what I think the technology does for all of us. And probably Rolling Stones, Mick Jagger, this was 7 days after his TAVR procedure, doing an Instagram dance. And I always say this is the best evidence for this therapy, right? He's the best ambassador for it. If he can do that, most of us can. So when we don't do this, I think this is important because it's very important to understand when we can't do it. Because otherwise, if we do it just in everybody, we're going to have problems. And this is where we invest most of our time. So for example, if it's a bicuspid valve, which is calcified, these valves sometimes, if you think about it, it's like a fish mouth opening, so it may not work the best. And then what happens is we can get leakages around it and cause problems. If the calcification is too much, this calcification can open like a book and then damage the surroundings. So we look at that with our imaging specialist and understand the risk, because what we don't want to do, a less invasive procedure, and then you need an emergency open heart surgery, which is really bad. It can also block sometimes the blood supply to the heart, which becomes a life-threatening emergency instantly. So again, we can predict these problems quite well. So when we come back to you and say, TAVR is not a good option, it's not because we don't want to do it, it's because it's going to be riskier in a way for you. So these are some of the things we take into consideration in our decision making. And that's why when you come for consultation, you see both surgeons and cardiologists together, and we tell you, we're going to discuss it and come back to you. There are a lot of novel therapies now coming through. If you see that one of the valves I showed you, we surgeons implant, is called a biological valve. We can, once it degenerates after 15 years or 12 years or 18 years, we can now put a TAVR device inside it as well, and it's called a valve in a valve. And this therapy has really blossomed into its own domain now, and this has become a very dominant therapy for most of the patients. And this essentially gives patients opportunity to avoid second open heart surgery, and also gives them an opportunity to avoid anticoagulation, which you probably don't want to have. This is one of my, people say, which is the case you remember most. This is a 29-year-old woman who had got pregnant after trying many years. And then she went into pulmonary edema, lung got flooded. And this was in Oman, Muscat. I flew there, and we did these 2 valve-in-valve cases, and she delivered a healthy child after 15 days. If we had done a second open heart surgery in her, she would have lost the child and probably had higher risk herself as well. So this therapy area has really revolutionized everything. And again, I would just want to emphasize that that has led to the next revolution about mitral valves, tricuspid valves. And very quickly, for the sake of time, as I said, for mitral valves, surgeons have adapted to less invasive mitral open heart surgery, such as this. So we can do now mitral valve repair or replacement through smaller keyholes or robotic procedures. At the same time, we can do transcatheter repairs, and Dr. Suraja is world-renowned for his transcatheter mitral repairs. And this is what he does, is so-called mitral clip, or a clip procedure, where if the valve is leaking, you essentially glue together two leaflets with a device, and then with that device, you abolish or reduce the leakage. And this is very important because you are avoiding an open heart surgery. Reducing the leakage can be more important than completely getting rid of it either. So we are, again, last 10 years have gone in research which he has led, and he has taught many centers all over the world on this clip procedure. There are times when we get patients with extremely challenging anatomies, such as this patient probably. You can see there is a TAVR device already there, and now he has got very calcified. It's hard for a surgeon sometimes to put sutures through that. And if they disrupt it, game is over. So we have now extrapolated our imaging specialist, like Dr. Kavalkante is here. He is one of our major team players for that reason. Is we can plan this, as I said, we can implant virtual valves and see, can I do this procedure or not? And this patient, for example, was done nearly 5 years ago when I was in London. And all this creativity really has helped a lot of patients. These are the patients who have no other option today. But because of these particular extrapolations, we can treat them successfully. We can also use them robotically and in hybrid way. And this is just to show you one of the cases where a TAVR device is being implanted in the mitral valve because it's very calcified, similar to the aortic valve in a way. And we can now implant it under vision if needed to avoid some other issues which happen when we do this. We are also doing a lot of new trials in terms of dedicated mitral devices. And very quickly, this is, again, Medtronic is a company which is local. This is the device they implant. So we have 2 trials running at present in Abbott Northwestern or maybe 6 trials soon. One is the Tendyne device and one is the Intrepid device. And just to show you how it looks like, again, through smaller incisions so that the patient recovery is faster. This can be done in only few selected patients at present, but as the therapy gets mature, in more and more so. Tricuspid valve, which is on the right side, which was rightly so called forgotten valve, now it's not forgotten anymore. And we have a lot of new technologies to address that valve as well. Surgeons are usually reluctant to operate on this valve because by the time patients come to us, it's quite late. So again, we have to put a lot of emphasis on education in future. But this is one of the pictures from Abbott Northwestern when the first tricuspid clip was implanted in the triluminous study. And again, thanks to all the support here from not just the community research staff, but everyone. It's an investment of the society really here. We are the highest enrollers in that trial led by Dr. Suraja. There are new valve replacement. This is a 91-year-old woman where we replaced a heart valve. And the best thing any patient has ever told me at that age is, after 1 month, she said, I actually went for a dance on Wednesday. And I said, wow, this is just great. So options, lastly, also bring challenges. It's nice to have options, but options also bring challenges because we have to choose now which option is best for a patient. I may be biased towards one. He may be biased towards something else. We have to actually take that out completely. And I think we have to also understand limitations. And we always end our talk by showing our own complications because it reminds us of what we should do better. These are some of the patients where we used a technology, but it really didn't work very well as we thought. And that learning has benefited future patients then. And luckily, we plan everything beforehand. We never go in a patient with plan A only. We always go with plan B and plan C as well. And this is really, really important. We want a long-term benefit in a patient. We don't want to feel good when you walk out of the hospital after a few days. We want to feel good when we see you after a few years. And that has always been our focus. So this is the real birth of Heart Team. We are not independent operating people anymore. This is not me, by the way, but it could be me a few years ago. A single type A personality waving, this is what I do. But now we are more like a team. Everybody is important in our team. Cardiology, surgery, anesthetist, ICU, imaging specialists, research staff, and that brings a lot of maturity and a way we look at every problem. This is all to do with patient focus. And this is not just a line. This is what we practice every day for years. We look at definitely less invasive options, but we don't hesitate to tell you that if that option is not good for you. And there are times, I practiced in New York and London, patients will go to different centers. It's fine, it's not a problem. I always tell patients that it's not about anything, but we are thinking of mainly what's good for you. This is what Val Center really brings together, is we have a combined patient consideration. We look at all these patients together, and I think this is very critical in future. We have excellent intraoperative support. When we do these procedures, the whole team is there. It's not just a single pair of eye. There are many brains behind making it successful. And lastly, I think least is, I never thought, I used to come and visit here from London. I used to say how people live here in winter. And there I am now. I'm a part of this community and really enjoying everything here. So thank you for the opportunity to share my thoughts. Thank you.
I learn something every time I listen to him speak, and I just learned that you need a picture of you in winter to add to that collage. So we'll take care of it after we're done here. We'll just go right outside. So thank you. Obviously, marvelous presentation. So we're gonna now transition, and we're gonna do a patient feature. As many of you are patients or related to patients and our families. Patients are all that we focus on. It is why we do what we do, and to help share some of the experiences that are made possible through the foundation and through research. We graciously have been able to have Chris Jackson, who is here in front, be featured today, and we're gonna first start with a video that describes her experience, and then we'll bring her up here and kind of talk about it a little bit more. So I guess that'll be the cue of the video then.
I'm Chris Jackson. I like to walk. I like to talk. I like to be with people. I have 9 grandkids that keep me busy. I love to bake. I never go to my kid's house without bringing cookies. Well, Munch is a handful. He's got a lot more energy than I do. He doesn't leave my side. He's a good doggy. I don't ever have a day when there's not something I look forward to. It first began in 2007. I had chemo for breast cancer, and by the time I had my 4th chemo, I was out of it. I had open heart surgery. I had the aortic valve replaced, and that was damaged by the chemo, and that was closing up rapidly. 5 or 6 years ago, my cardiologist, who at that time was Dr. Wes Peterson, said, well, you've developed another leak in the tricuspid valve. The good oxygen wasn't getting down to my legs. My legs felt like they weighed, 75 pounds each. Lo and behold, then I met up with dear Dr. Saraja.
Well, Chris was a really remarkable story because she's a breast cancer survivor, and she also had heart surgery before she came to see us many years ago. She survived a life-threatening condition once and then twice, and then despite all of those things, she was then left with tricuspid regurgitation.
His explanation was, first of all, not to worry.
She had been unusually tired and was struggling in terms of her energy.
He felt like by taking away the extra fluid that was collecting because of that leaky valve, that I would most certainly feel the difference.
She had come to us for a less invasive approach, and what we had to offer her was something that was only available through a research trial.
She wanted to live, not just live longer, but live life, have a quality of life. She's got kids and grandkids and a dog and cookies to bake. So, I mean, she was motivated, and that motivates us too.
Historically, treatment of the tricuspid valve has been a risky proposition for many patients, and this new therapy offers a way to treat it without undertaking those usually risky propositions, and that's what she got.
What we offered her was the triluminate trial, which is a tricuspid clip.
We go through a vein in the leg, and we bring this therapy up to the heart. And essentially, we use it to kind of put the valve back together.
He said that he had done, I think up to that point, some 65 or 70 of them, and they were all successful.
We did the first in the world in 2017, and the current generation device, we did the first in the world in 2019. And right now, we're very proud of where we are.
I could have gone home afterwards. I felt that good. I think I had it on a Friday, came home on Saturday, and my kids came over on Sunday expecting to find me in bed recuperating, and I was making breakfast for them.
What really made Chris special is her just excitement and willingness to participate, her excitement to do research for the future people.
It was really quite fun because being as that I had to stay overnight, the next day I got lots of various people coming in and say, "Oh, you're the one." Every single doctor, they were all just, I would love to have them all come over and be able to give them a hug.
It's a very safe and effective therapy, and at least in the early data, it's been shown to improve the quality of lives of our patients dramatically.
This is my oldest, he's 33. Well, I'm most grateful for my family. Also for a group of doctors who have been, they believed in me, they believe in what they're doing, they're passionate about what they're doing. You have a whole different feeling of love for these people. Your life is in their hands, and the fact that they make it so comfortable for you to trust, thanks isn't enough.
Okay, where's the Kleenex? Thank you, Chris. Chris, would you like to come up here? And I'd like to invite Dr. Bapat and Kate, our coordinator, if you have room, and Dr. Murad. And you have not introduced or met Dr. Murad yet, but Dr. Murad is a cardiologist like me, does incredibly complex work over in St. Paul, and has lots of experiences to share as well. Thank you. Yes, please sit here. Kate, you saw in the video our star research coordinator as well. And so, where's Dr. Cavalcante? Did he make it too? Hey, Joao, do you pull up a chair? And this is Dr. Cavalcante. So, Joao is hails from a warmer place on earth called Brazil. And he was charged with bringing in the Latin flavor to our group, as well as those incredible images that you saw. So he's an imaging specialist. And so I have the pleasure of asking you or talking to you and caring for you, and it's been an amazing journey. And what's your thoughts on this? Tell us, Chris.
One word, amazing. An experience that, I never thought I'd get famous because of having this done, but it really has been a life-changing experience. And it's only because these guys just made it so incredibly easy. Never once did my blood pressure go up. I was relaxed, and I was happy. I was like, wow, this was great. Give me my popsicles, which they did. It was the first thing. Once I woke up, I got my popsicles. Yeah, there was no fear whatsoever, just pure comfort.
So when we were talking to you about doing research and telling you that, well, this is not something that's widely available, what did you think of that?
Well, I was told when I first, my first cardiologist was the one who actually invented the clip, but then it was only for the mitral valve. And he told me when I developed this leak in the tricuspid valve, he said, maybe someday we'll be able to use that for the tricuspid valve. But that was, like 5 or 6 years ago. So when I first heard about the fact that it was being used, I asked my current cardiologist, Dr. Samara, about it, and they weren't real happy. They thought the risk would be the results would not be worth the risk. And I kind of proceeded and I just didn't shut up about it. I gave it until they finally said, okay. And so I think Kate was the first one I talked to, dear Kate, who I just feel has become a good friend. And she's the one who sort of promoted me. And lots of interviews, lots of tests. Mine was a little different because I have a lead that went right through the center of that right ventricle. And they were concerned about that lead going to be in the way and that it might be disturbed. And so I didn't get that much encouragement from my other cardiologists. And then I met dear Dr. Saraja, and he said, no, nothing to worry about. It's just going to be easy. And proof of it is that afterwards, there's a video of him walking into the room where there were several people watching. And he went,
yes.
Wasn't that fun? And they stood up and gave him a standing ovation. So I guess.
Yeah, we had some onlookers that day. They're very curious to see how you would turn out. And everyone was really, really happy to see it went well. So
it went well.
And how's your life been impacted by being involved in this and being part of something early?
Wow, it's life-changing to go from being so exhausted and so completely like, man, I don't have any quality of life anymore, to going to the other side where I get up in the morning and I'm anxious to get moving. I look forward to every day, every hour of every day, and it's just a whole different feeling. I continue to be in AFib, so that's kind of a negative for me, but this has even changed that to where I can survive.
So gracious of you to share that. Bilal, you are a practicing cardiologist, have been here for many years. What does this story resonate with you in terms of patients with leaky tricuspid valves or valves in general?
Yeah, thank you. It's been a privilege being here today.
Yeah.
I think that nothing has changed more in medicine than this area of cardiovascular diseases and valve therapies. And as Dr. Bapat was mentioning earlier, the last 20 years has just seen a dramatic revolution. And from seeing a patient like her being treated and walk out of the hospital and come back to a fairly normal quality of life is what drives all of us on this stage every single day. And I think if you talk to all of us in person, you'll be able to sense the passion with what we do. And that's really is, the driver for that really is this outcome. It is particularly fun to treat patients who are elderly because they have a zest to live. They want to live longer. They have families. They have grandkids. And one of the fundamental, when Dr. Baba talked about how do we assess the therapy, it's not just about an age. We've seen time and time again that our elderly patients have a passion. They want to live, and we've offered these therapies so they can feel better and get back to their normal life. So I think this has been an incredible driving force for us as operators to learn more and more about improve our skill set, improve our operations, and how do we maximize our programs in terms of efficiency and quality of care, minimize complications, and help our patients and their families connect with each other for longer. So it's been an incredible journey on the St. Paul side as well. And you're right, this is what makes me go to work every single day.
Journey, that's a good word for it.
So Joao, so is it this way in Latin America as well as Minnesota? Bring us your international perspective. Is this a universal phenomenon?
Well, it's not as cold as it is. I can attest for that. But it's so beautiful to hear your story, Chris, and of many others that we have had the luxury to be involved with. If you dial it back, we still have a lot to do in terms of bringing awareness. I was just finishing rounds yesterday, and there was somebody in the mid-70s, similar to you, AFib, pacemaker, and you look back, she had tricuspid regurgitation, which is one of these valves that leak, for at least 3 years back. But it flies under the radar screen. Why? Well, I'm getting old. This is just, and they don't have a good quality of life. I hate taking the diuretics because it makes me go to the bathroom. I cannot actually leave my house. What quality of life is that? And so we need to train our physicians to recognize, check your valves, please. The same way that you're going to do your breast exam, I guess you cannot check your valves. You've got to ask your doctors to have your valves checked. That's important. Technology now allows us to do that without need of open heart surgery, Dr. Bapat. But, if you need that, there's that option. But you need to have your valves checked. And then bring the awareness. If the symptoms don't make quite sense, that's not normal. And go ahead and get involved. And one last thing. Thank you for participating in research. A lot of the patients that Kate and Paul has brought us through Triluminate, many other studies, I remember them saying, gosh, I could not sleep the night before to know whether I was going to be randomized to treatment or to medications, right? I mean, there's a 50-50 chance that you could, or maybe a little bit less, but what if that patient would have been randomized? We still don't know in some therapies. Others are very well established, but it's through this journey that it benefits you, but benefit many others is what we're going to learn. So, thank you.
No, the bravery of being involved in research early on is so key to how we can affect millions of people's lives in the future, for sure. So we do have the luxury of you having had both the open and the catheter-based approach, and what you had, was it 2009 or 2007? 2008. Okay, I got it wrong on both sides. But back then, that aortic valve replacement was a life-saving procedure. Could you tell us a little bit about that and how it was for you?
Well, that was that was not the cup of tea that this one was, for sure. I was in the hospital for 11 days, of which about half of it was spent in intensive care due to some complications. I'm part of the Zipper Club. The rehab was tough because you didn't just get up right away and move. It was just almost an hour by hour recovery. And as my daughter, who's here with me, will attest, I didn't come back from that right away. That was a long ordeal, and it just so happened that the surgery was the day after my 50th wedding anniversary. And when they told me that they wanted to do it on the 2nd, I started to cry. And Dr. Kashatri said, "Oh, is there something wrong?" And I said, "Yes, that's my 50th wedding anniversary." He said, "Then let's do it the next day." I said, "Fine." I said, "Fine." So we celebrated the night before, the whole entire family. But I remember pictures of the kids crying, thinking it might have been the last they were going to see of me. And to wake up from that one was, I didn't sleep that well the night before, as I did with this one. A lot more traumatic, and of course, I could never wear a strapless gown again after having the big scar up the middle of you.
I'm almost sorry I asked. but I honestly didn't know. I mean, the long and short of it is, again, it was a life-saving procedure.
It was a
Dr.
life-saving
Kashetri saved your life.
Yes,
The recovery might be what it is, but you're here today because of that procedure.
Oh, gosh, yes.
Yeah.
Yes.
Yeah, so I'm sorry. We'll kind of end on a positive note there. So Kate, you have been just our amazing research coordinator and carrying Chris through this journey. Tell us about what it's like to be involved in research and taking patients through this journey.
Sure.
I feel like I have the best job in the world. I mean, this is amazing to meet patients like you and continue to go forward. I remember my coworker Sarah, when she was trialing the MitraClip with Dr. Peterson, she said, you know, people were skeptical. People said, I don't think this is going to work, and they just kept pushing forward, and look where we're at now, doing the clip on the tricuspid valve. So it's just wonderful to see patients in progress.
She's the best.
Vinny, your perspective on things, hearing Chris's story and her journey through cardiac surgery, transcatheter world. Give us your perspective.
I think my first perspective is I have to think of women wearing strapless gowns now when I operate them. So I think thanks for reminding me. Sometimes not at all. As I said, patient expectation is most important, right? And this is very critical. I've been very fortunate in many ways that as a surgeon, as I said, I showed that cartoon of a type A surgeon. That's what we are, and that's what we become surgeons probably. But I was mentored by right people to have the mind open to possibilities. And I think I've been really fortunate to see patients like you, and then have that much at least open mind and welcome these technologies in my world. I'm never afraid of it because I still think there is a role for growth in every possible way. I have most fascinating evening conversations, for example, with Dr. Cavalcante, who happens to be my neighbor. And we spend a lot of time brainstorming imaging. And most of my surgical colleagues don't even understand it, is why are you even interested in that? Because I think this is fascinating, is what we do, and we have a word called translation, is what we think, what we do, what engineers design on the back bench. This is translation. What you see here today in her story is how all that effort really benefits a patient. So I'm actually really happy what I do, but I'm more thrilled to see that I'm part of this, whatever minimum part that is, and I play that role hopefully positively in future as well. Thanks.
For the record, he does not have a saw that big in the OR. Just so you know, on that cartoon, it's much smaller. So at this point, we do have an opportunity and some time for some questions. We'd love to answer a few here. I think, Kristen, do you have some on the card you want to bring up? And then I think there's some cards at your table if you want to write down some things, and perhaps we could spend a little bit of time on this. So sorry, I should have cued you. Okay. Okay, this is a good one. Okay, Vinny. So, what are the sources for replacement valves, and what is the estimated longevity of each?
So, as I said, there's mechanical valves and there are biological valves. The mechanical valves have become more streamlined now. Most of them are made of pyrrolite carbon or titanium. So they tend to last, as I say, 100 years if they work well, but they need anticoagulation. The tissue valves, which many a times are called pig valves, for example, that's how it started. But essentially, they come now from another source as well, which is essentially cow, or it's the hard covering of a cow. And they last anything between 12 years to 18 years in the aortic area, and they last anything between 10 to 15 years in the mitral area. And the reason, if you remember, I said in my talk that mitral valve closes at a much higher pressure. So the closing pressure is the one which causes turbulence and degeneration. There are newer technologies which are being applied to this tissue so that they can last longer. We have a device called now Inspiris, but hopefully we'll see less calcification in future.
Beautiful. Here's one. How about Joao? What are some important factors in an open heart TAVR decision?
Yeah, so as Dr. Bapat showed before some of the images, you have to know the patient inside out, literally. What are the comorbidities, what are the problems that they have in addition to the valve? As well as once you do that CAT scan, how can we get to the valve? So can we go through the arteries? how much calcification is there, how good is the function of the heart. All those things we have to balance and present and wait what will be the best treatment for these patients.
Beautiful. Bilal, how about one for you? How does rheumatic fever affect damage, or how does rheumatic fever damage heart valves?
Well, rheumatic fever is the consequence of an infection typically from streptococcal infection, something very common in certainly my part of the world. And it causes the infection causes inflammation, and that inflammatory response makes the leaflets of the mitral valve typically very thick and restricted in its opening. So unlike the aging process, which results in the buildup of calcium, these valve leaflets are not that hardened and calcified. They're just more what we call fibrotic because they become thickened from inflammation. So they're a little bit easier in terms of opening with the balloon, whereas the valves that are hardened from calcium generally need to be replaced or repaired surgically, or in the future with Dr. Suraja, the work that he's doing, the Tendyne valve, hopefully we'll be able to replace those even without open heart surgery someday.
A lot of these questions are medical, but if any of you have questions for Chris, please let me know. You can pass those too. So, let's see here. Okay, Joao, can you talk some about pacemaker lead tricuspid damage?
Yeah, so pacemakers and defibrillators are placed on the heart to do a purpose, right? To pace the heart or to shock the heart when that heart is weak. In the process of getting through, to get into the heart, it has to pass through that valve, the tricuspid valve. And typically we don't put a pacemaker or defibrillator with an imaging. We do x-rays and we place and we check. Over time, there has been an increased awareness that these leads can make the valve not close properly, depending on how the lead sits. Sometimes it has nothing to do with the tricuspid valve. The lead is moving and there is a leak of the valve. So with imaging, we can tease it out. Is the problem caused by the lead or caused by the valve or the combination of both? So sometimes we need to remove that lead so that we can place a clip. Sometimes we can treat that valve without having to remove the lead with new devices like we have now available with replacement. Instead of the clip, we can replace that valve as well without having to touch the lead.
Great. Vinny, can you talk a little bit about pros and cons of robotic valve surgery and also minimally invasive repair?
So again, just to highlight this, that for the aortic valve, robotic surgery is not possible. So aortic valve is mainly the keyhole operations, two types which I showed. One is a small cut here in the middle, one on the side. For the mitral and tricuspid, however, we can do less invasive procedures, and they can be either video assisted. That means you can make a small cut here on the side, or you can do it same way but with robotic assisted. Usually speaking, less invasive operations take longer time, and that's generally the rule of thumb, because your visibility and the technical assistance you can get during operation is limited to the surgeon. So we have to always tailor it to the patient's condition, the heart condition. For example, if the heart is not functioning very well, a longer operation is not going to be good for that patient, although we can do it through a small hole. So in some patients, our focus actually is on getting maximal access, the zipper club, but at the same time, I can do the operation faster, because that's what is going to get the patient out of the hospital. So robotic operations are done in niche centers, and now hopefully within few months now at Abbott Northwestern as well, we'll be getting a surgeon who will be focused on robotic or less invasive mitral procedures. And by 2023, we'll have a team of 2 or 3 surgeons doing that.
Fantastic. So lots of pros and cons to discuss there, very complex. Kate, how does one know when they have valve disease?
Oh my gosh, up here with a bunch of doctors.
Love it.
I would say, obviously, you have symptoms. A lot of patients, like you said, come to us thinking, oh, I'm 80. Of course I'm fatigued. Of course I'm short of breath. But it's not always the age. I would say get checked out. Get a cardiologist. annually.
Yeah. So see a doctor.
Yeah. See a doctor.
It's kind of like getting your oil changed in your car. You gotta like get a checkup, and sometimes the check engine light comes on. So okay. Bilal, what is the risk of stroke with TAVR? Don't these particles just break off and fly everywhere when we put things across valves?
So in the research trials, the risk of a stroke generally is quoted to be between 2 to 3% is what we tell patients. The risk of that's the risk of a major stroke. It is possible that minor strokes that are clinically not that relevant, that don't really impact your quality of life that much, may occur. These are harder to detect. But I think our experience here in our hospitals as well has taught us as well that about 2 in 100 chance that you're likely to have a stroke. Now, there are some devices that are available out there to help us protect it. The effectiveness has been sort of questioned. Hasn't been demonstrated to be completely preventive of, doesn't completely prevent you from having a stroke. So the utilization of those devices is still sort of in question and is being evolved, but I would say generally about 2%.
Perfect. So Vinny, help us set the record straight here. It says Chris's stay was 11 days. Are we better than that now?
Absolutely. I think, again, 5 fingers are not same. So usually open heart surgery stay is 4 to 5 days or 5 to 6 days, depending upon what those 3 factors I showed you: age, condition of the heart, and other comorbidities. This is really critical. But probably what I suspect is from the chemotherapy you had before and certain other challenges, there were some initial tweaking, as we call it, or fine-tuning you needed in ICU was more. And this is where, in my opinion, I worked in 2 really big academic centers before, and I always said that my main hesitation of moving here was Abbott Northwestern, how the intensive care is. And this is the best intensive care I've ever seen. So if you spend 5 days there, I think they were needed. And it just reflected the condition of your heart at that point, and probably the damage chemotherapy had caused to rest of the organs as well. But it's usually less now.
Fantastic. So with that, we're going to run out of time here, but we're keeping these cards, and we're going to respond to these by email, or how we do it in writing. I can't remember. Somebody said we're going to do this in writing, but I want to thank you all for coming. We'll be around for a little bit if you have some brief questions you want to ask us. But Chris, thank you so much for sharing your story. And thanks for taking the steps to be in research. I also want to just acknowledge one other person who's very special to me, and that's Shirley over here. So Shirley, she's been my patient for many years, and she has graciously said that we can share part of her story. She had what Chris had 4 years ago, and she's now going to be 93. So, and she shows up with a different hat at every event. And
find out that I could help somebody. I thank you.
So anyway, thank you all for coming and being a part of our event today. And again, it's just a real pleasure to have you all. Thank you for being interested in research in our foundation. And we look forward to working with you and seeing you all again in the future, okay? Thank you. Have a great rest of the weekend.